much resources and funding is the government giving out to deal with these problems?
I don't have the best statistics for those.
But I think it's surprisingly little.
Very little. For those ones under 5, very little. You can find very many clinics without syrups. Very many clinics without syrups.
Syrup
Just
what?
find syrups for children.
What's syrup?
Syrup. You know syrups?
No?
Children's drugs are in form of syrups.
Oh, for which diseases?
For almost all, they make them in form of syrups, not tablets.
Yeah.
So you might find very many health centers without syrups. And they are giving tablets and estimating doses. You see? Because when you give a tablet of Septrin, you're estimating.
Yeah.
You break it and estimate. Yet with a syrup, the dose is proper.
Yeah. For the baby.
For the baby.
Yeah.
Because they will say 5 mils, 2.5 mils,
Yeah.
10 mils, but how will you know with a tablet?
So you're saying that the syrup's there, but they're too expensive for the
Syrups are
mothers
expensive
to
because
afford.
with this tablet you can buy it at 100 shillings. But a syrup will be at 3,000.
Yeah.
How many people will buy it? So it becomes very hard.
So is it fair to say that the reason these other medicines are so expensive is because too much money is being spent on fighting AIDS?
These days too much money is being spent on fighting AIDS and forgetting other diseases. They fight AIDS, malaria and tuberculosis and forget other diseases.
And yet you're working here. You've chosen to work here. And this clinic is, as far as I can tell, is more focused on
HIV.
fighting AIDS than anything else.
It's on HIV. When you test negative, you're not a client here.
Are you familiar with the names of those conditions?
Which ones exactly?
This,
The adverse effects.
this one, leukopenia.
They all rarely occur.
But how do you know when it occurs? How can you tell when it occurs?
You can do blood tests. We normally do the full blood counts after some time.
Yeah. So you'd include CD4 counting.
And CD4 counts you do every after 3 months.
Yeah.
And then full blood counts, especially those on nevirapine. Yeah.
Because leukopenia is associated with T-cell decline, people are concerned that by giving them Septrin, it's being used as a pretext to put people on ARV'S. Is that true?
That what?
Since leukopenia is associated with CD4 count decline, people are concerned that they're being given Septrin to create the pretext by which to introduce ARV'S.
What?
Yeah.
I've never heard of that.
Well, leukopenia causes CD4 decline.
Decline, right?
Yeah. So when people are put on Septrin, their CD4 count comes down, which will justify putting them on ARV'S.
No. When they're on Septrin, the CD4 goes down. The CD4 goes down.
According to the manufacturer.
Because,
has this been observed?
no, we haven't.
But how would you be able to distinguish between somebody's CD4 count going down because of the drug or because of the virus that they're supposed to be infected with?
We think it's normally because of the virus, not normally because of the Septrin. This is, in very rare cases, it can happen.
Still, the question is valid, I think. How could it be distinguished between somebody taking Septrin and their CD4 count coming down and the presumption that It's the infection with HIV that's causing it to come down.
Clinically, the patient will look. The patient whose CD4 has gone down will clinically present. They will be deteriorating day by day. They will be complaining of infections day by day.
Yeah.
Yes, clinically.
But those infections occur among people who are deemed to be HIV negative.
No, the opportunistic infections.
Yeah.
And they occur with people who are HIV negative.
Yeah.
Well, yeah.
Well,
rarely do they occur. But the patient whose immunity has gone down, they will present with infections we shall be observing. Yes. So those patients will be deteriorating. They'll be deteriorating as their CD4s go down. I think they'll be deteriorating day by day.
As we've seen in this book, on the first or third page, there are many common health concerns for African people, not just children but also adults.
Yes.
The epidemics of TB and malaria and fever. So, and I think it's recognised, but you can correct me if I'm wrong, that people who are deemed to be HIV negative, they also present with the same symptoms.
They do. Yes, they do.
So then back to the question of leukopenia being a side effect of Septrin. You're saying that their CD4, people given Septrin can have their CD4 count going down, but they'll also present with other infections. But neither those other infections nor the CD4 count decline are specific to AIDS.
No, they are CD4. No. Get you right.
People can be sick.
Yes, even when they are HIV negative.
Yeah, whether they're negative or positive.
And their CD4
their
go
CD4
down.
count can go down.
Yes, I know that.
But the problem that I'm really referring to is that when it comes down to a certain point, it's used to justify putting people on ARV'S, which they're then encouraged to take for the rest of their lives.
But here we first check you to see that you are really HIV positive, and then we do your CD4 counts. If they are below 250, that's when you're put on drugs.
Yeah.
Here in Uganda. That is the criteria.
Yeah.
Yes. I don't think a person who is HIV negative can have their CD4 go down beyond that. I don't think.
Well,
can they? At least it can go at least up to 500 or 350.
Have you ever noticed people with TB who are deemed to be HIV negative on HIV tests having their CD4 counts checked?
And when they were low?
As far as I know, they're not being checked.
They have not been checked. And it also that
the patients with advanced TB are not having their CD4 cells checked.
They had never been checked, their CD4.
They're not being asked.
How about their HIV status?
Well, maybe they've been tested for using an HIV test, but they've been presumed to be negative for HIV. They're still positive for TB, but they're not. There are no services to collect data on a mass scale from CD4 counting.
Yes, that is very common because, again, it's due to the poverty, because very few centers have CD4 machines.
Well,
people are started on drugs clinically.
If somebody has TB, they need treatment for TB. They don't need to have the CD4 cells checked anyway, apparently.
Yes.
But according to some articles that I've come across, in here, CD4 counting is quite arbitrary. This one here. So
It's possible. That's why we insist on checking the CD, HIV tests here before clients are being made files for.
yeah.
We repeat their tests to confirm that they are really HIV positive. Yes.
So far we've covered opportunistic infections. They're not specific to HIV. The CD4 counting is not specific to HIV.
Yes.
And now we're onto the HIV test. So I'd like to ask you which test. I know they're using 3 tests, but which test of those 3
It's the best.
detects the actual virus?
The DNA PCR, which we only do here on children because it's quite expensive. We do only rapid tests to adults.
Yeah. Okay. So what you're saying is that PCR is specific, that it detects the actual virus and measures the amount of virus in people's blood.
Exactly.
But
now we don't use it.
you don't use it.
We only use it to children because it's quite expensive.
How much does it cost, if I might ask?
It can go up to 60,000.
Really?
DNA, even 150 in some centers, 150,000 a person. So we only do it to children here. Yes. Children who have not been breastfeeding.
Yeah. And by PCR, are you referring to viral load testing?
Yes.
So there's a study here that was done in 2006 that revealed that viral load tests used for more than a decade to calculate progression to disease.
The PCR is not a viral load. Viral load is different.
Well, PCR is a technique that's used
It's a
to measure
technique that
viral
measures
load.
the antigen. The other ones are measuring antibodies.
Right.
Yes.
And it's,
So,
but do you recognize this?
which one?
This is the test kit insert for PCR. And just there is a disclaimer.
Yes, because this one we do it after being confirming that you're HIV positive. We go on to check on the viral load. This one works very much.
Yeah.
Beginning, before you start drugs, you know your viral load, and then you go on to test after 3 months to see whether the virus is going down,
Yeah.
up to undetectable.
And what's that
Counts.
test called? What's that test called?
The what?
What's the name of the brand name of the test?
Which test now?
This one, the one you're referring to.
I'm not very sure of it, but we do the viral load.
Yeah, I think they use this test to detect antigens and viral load.
This one is for both.
I think.
Because for us we do differently. We do them differently. We do the PCR separately from the viral load.
Yeah.
Yes.
So
This one will show whether you are resisting to drugs. Because if the viral load goes down and again up, then you know there is something wrong going on.
yeah.
Yes.
But viral load has been reported by prominent researchers as being not viral.
It's what? It's what?
Well, the test is only looking for fragments of DNA and RNA purporting to be specific to the HIV virus.
Okay.
But this is also indicative of the test results being non-specific.
Okay.
Because it says that it's not to be used as a screening test for HIV. heard of the ELISA test?
I've heard of it. The ELISA.
That's information printed by the manufacturer of the ELISA test.
I've heard of it.
So can you give me a comment on those two disclaimers?
Which one and which one?
Well, both, because both companies have printed information that effectively states that the tests are non-specific, so therefore it can't be determined that somebody's HIV positive.
You know, with HIV, because it's still a new disease, very many research is going on. Very many people are trying, even herbalists are trying to find out some of these things.
Yeah.
So very many things are coming up, very many drugs are coming up, a lot of information. When you go to the internet, you get a lot of it. So we are there, you know. Whatever comes up, whatever the ministry tells us to do is what we really do, because we think that the ministry has come up with something that has been researched on.
Yeah.
Yes. Otherwise, very many studies are going on. When you go to Mulago, we have very many studies here. We are putting patients on different studies.
Yeah.
Finding out TB treatment with ARV'S, and again switching off, you know, certain types of ARV'S, pregnant mothers, and then on what drug, and yet on TB, you know.
Yeah.
Very.
I'm aware of that, and this is why people are saying that research is great and beneficial for researchers.
Yes.
But how does that research
and very many
translate into clinical health benefits for patients?
Yes.
When remembering that we've got these anomalies. 94% of infants are dying of other causes, but there's no money available for that. And the Ministry of Health is as uninterested in dealing with more important health issues than as medical professionals themselves.
Yes. So we are there.
There's lots of research going on.
Lots of research. They come here, find us, ask us questions, take patients, you know. 5 years we've been with Case Western. I was with Sabrina. She was here, she went back to UK the other month, and she's been here for 5 years doing her research on TB. We've been referring to her patients, and I think she got the patients she wanted.
But that's beneficial to her, but how do the patients benefit?
The patients will not benefit, but the future will benefit maybe.
We're 26 years down the line now. $250 billion has apparently been spent on so-called research.
Because we can't get the best when people have not researched. We can't get the best. Now, very many people have been given the vaccine, the HIV vaccine.
Yeah, the vaccine researchers don't want to experiment on themselves. And as a result, they've continued to fail. 63 vaccine trials have failed miserably, and people have suffered in those trials. And most of the people come from poor areas in third world countries, and they're unemployed, and they've been exploited.
Exactly. So we are there. For us, we are here to do the work. What they tell us is what we do.